our lecture is the drug treatment in Parkinson disease, right? So first of all, now tell me, are you listening me properly? Can you hear me clearly? So we will continue further. Anyone from your side who is there? Okay, very fine. My name is Dr. Imranul Haq, and we are going to discuss the drug treatment for Parkinson disease. You know, Parkinson disease is one of the neurodegenerative disease of the brain, right? So other neurodegenerative diseases, we have Alzheimer disease, we have multiple sclerosis, we have amyotrophic lateral sclerosis, right? So, but we have to focus the neurodegenerative disease, which is Parkinson disease. So first point that you must know, the Parkinson disease is due to destruction of the dopaminergic neuron in the substantia nigra, right? So deficiency of dopamine activity due to destruction of dopaminergic neurons. And now one of you tell me, dopamine is basically inhibitory neurotransmitter or excitatory neurotransmitter? Because in the brain, you know, there is a balance activity between excitatory neurotransmitter and inhibitory neurotransmitter. So when there is imbalance in between these activities like excitatory or inhibitory, then there is a problem that can occur. So correct answer from your side, this is producing inhibitory activity. So definitely what will happen? It's a general logical point. If inhibitory activity is subsided or decreased, definitely there is a disturbance in the balance. So excitatory activity can overcome this inhibitory activity, right? So this we will further see. You know, one of the famous personality of the world, Muhammad Ali Kalle, that having that person having this disease, right? So that is why I have mentioned the picture of this well-known person. Four major symptoms of, and basically this neurological progressive disorder in which we have movement disorder. We will find the movement disorder. So four major symptoms of Parkinson disease. One is tremor, number two is rigidity, number three is bradykinesia, in which there is slowness in initiation of movement and carrying out the voluntary activity, and postural instability. So these are the major symptoms. Etiology, that is basically idiopathic. That means no genetic link or mechanism is unknown, but the probable causes it occur. Generally, it is said that over the age of 60, this disease can occur. And a very important point during our student life, one of my professor who was conducting the pharmacology lecture, he told us that we cannot have Parkinson disease if we start smoking. So we were very much in shock. So that means if we want to avoid the Parkinson disease, so we can start smoking. So then he smiled and told us that because you will not reaches up to the age of 60 if you are going to start smoking, so maybe there is a chance that you wouldn't be able to cross the age 60, which is generally necessary for the development of Parkinson disease. So it was just a joke, right? So cerebral atherosclerosis, virus encephalitis, carbon monoxide poisoning, manganese poisoning, and it could be drug induced, especially antipsychotic drug or drug that are going to block dopamine receptor that are going to block the activity of amines, right? And already we have discussed that in Parkinson disease, there is deficiency of dopamine. So if we are using drug that is also responsible, for example, the major group of drug is the antipsychotic drug, because antipsychotic drug, they are going to block the activity of amines like dopamine, catecholamines, right? 5-hydroxytryptamine, right? So this is important point, right? So clinically or practically, if a person having taking antipsychotic drug and also have Parkinson disease, then the treatment is very tricky, because if that person is taking antipsychotic drug, definitely it will further decrease the activity of dopamine, so it will exaggerate the Parkinson problem. Now, this point also we have discussed in these cell death result in dopamine. So the inhibitory activity is not going to occur. So the loss of inhibitory effect of dopamine result in more production of acetylcholine. So inhibitory activity is counterbalanced normally with excitatory neurotransmitter, which is acetylcholine. So when there is deficiency in the dopamine, so inhibitory activity is less. So what will happen? The excitatory activity is going to increase, and that occurs due to which neurotransmitter? That is the acetylcholine. So there is a imbalance between dopamine and acetylcholine. Goal of treatment: alleviate the symptoms, prevent or limit complications, and slow progression of the disease. Because one point is important, it's a progressive disease, neurological progressive disease. We cannot stop the disease progression phenomena, but we can slow down this phenomenon, right? So that is why in the initial therapy that we will see, that when we use levodopa, the initial response is excellent, because if the remaining neurons, because we have discussed that destruction of dopaminergic neuron is responsible to decrease the level of dopamine. So initial therapy would be effective, because at that time the remaining dopaminergic neurons, they are sufficient to try to overcome this activity when we use the drug. But with the passage of time, after 3 or 5 years, there is lacking of response, that we will see. Now, in normal subject, there is a balance between dopamine, which is inhibitory activity, and acetylcholine having excitatory activity. When there is a balance, no problem. But problem arises and movement, motor activity is going to disturb when the level of or activity of acetylcholine is increased due to decreased level of dopamine. So at least what you must know, in Parkinson disease, there is an imbalance between inhibitory neurotransmitter and excitatory neurotransmitter. The problem is in inhibitory neurotransmitter, which is dopamine, due to destruction of dopaminergic neurons, right? So there is an imbalance. So what will happen? Increase activity of acetylcholine, so that we will observe in the form of movement disorder. Treatment: to balance, to restore dopamine, right? So we can overcome this problem. So main purpose is to restore the dopamine level, either giving a dopamine agonist or the drug that can enhances the synthesis or release of dopamine from the remaining neurons. Other option could be, dopamine is going, when it is released from the nerve terminals, so This is the normal phenomena. Anything which is released and it's going to bind with postsynaptic receptor. So there is an enzyme which is going to degrade or break down. So the action is going to be terminated. This is the normal phenomenon. So one of the options when we are required high level of dopamine or less amount of dopamine is being produced due to less number of dopaminergic neuron. So one of the phenomena could be to inhibit metabolism or degradation or breakdown of dopamine, right? So this is important point. So there is a group in which we will see that what are the drugs that can inhibit the metabolism of dopamine. When there is inhibition of its breakdown, its metabolism, so indirectly we can raise the level of dopamine, right? Other option could be to using anticholinergic drugs, right? Because movement disorder due to exaggerated or overactivity of acetylcholine. So one of the possible phenomena is to inhibit acetylcholine activity by using anticholinergic drugs. But the main treatment is to replace dopamine. This is the main treatment option, right? So anticholinergics could be adjuvant drug. So these are the drugs that are related to dopamine release, synthesis, or avoidance of its breakdown. So there are a number of drugs that we will see in these subsequent slides. So this is another option. Already we have discussed one of the options could be to use anticholinergic drugs. Now, this is one of the key drug, main drug, an exam-oriented drug, right? And levodopa. This is one of the commonly asked drug. Levodopa is a metabolic precursor of dopamine, right? What does it mean? Because when it crosses the blood-brain barrier and reaches the brain, immediately this levodopa is converted into dopamine. So this is the explanation of this. Levodopa is a metabolic precursor of dopamine. So immediately levodopa rapidly converted into dopamine. So there is a question that is often asked in the exam. In Parkinson's disease, there is a deficiency of dopamine. So why can't we use dopamine directly? Why we are using levodopa, and this levodopa first it will crosses the blood-brain barrier and then reaches the brain and then converted into dopamine and then produces its activity. Already we have mentioned here, dopamine does not cross the blood-brain barrier. So this is the reason. If we use dopamine as a drug in the treatment of Parkinson's disease, but that would be ineffective. Why? Because dopamine cannot crosses the blood-brain barrier. So that is why we'll have to use the metabolic precursor of dopamine, because it can crosses the blood-brain barrier and then it enter into the brain and convert it into dopamine. Okay. Dopamine does not cross the blood-brain barrier, but its immediate precursor levodopa is actively transported into the CNS and converted to dopamine. Clear? It restores dopaminergic neurotransmission in the neostriatum by enhancing the synthesis of dopamine in the surviving neurons of the substantia nigra that already we have discussed, right? And in early disease, the number of residual dopaminergic neurons in the substantia nigra, typically about 20% of normal, is adequate for conversion of levodopa to dopamine. So this is the reason, because it's a slowly progressive disease. So that means the drug that we are using, that is only responsible to put the patient symptom free, right? It relieves the symptoms, but it's not going to stop the disease progression phenomena. So this is the reason after 3 to 5 years, the use of this levodopa would be ineffective, because the survival neurons, they are going to decrease gradually, right? So they cannot compensate the dopamine level responsible to compensate this problem. Clear? Pharmacokinetics of this levodopa. Absorption from a small intestine is rapid, but important point, because food can delay its absorption. So that is why it is recommended. Ideally, levodopa should be administered on empty stomach, right? And the second point is metabolism. Two important phenomena involved for its breakdown. One is the decarboxylation process. That means we have an enzyme in the periphery, in the intestine, that is called dopa decarboxylase enzyme. It will break down the levodopa, metabolize the levodopa. Now, very interesting point that I'm going to ask, but another breakdown phenomena is the oxidation by monoamine oxidase enzyme and catechol O-methyl transferase, right? So monoamine oxidase enzyme intraneuronally, it breaks down the dopamine, and at synaptic cleft, catechol O-methyl transferase enzyme is responsible to break down dopamine, right? But one important point that I want to share with you, one of the breakdown phenomena is the decarboxylation, in which enzyme is responsible to break down the levodopa, dopa decarboxylase enzyme, which is present in the periphery or in the intestine because we are taking the drug orally. Now, what is the point that I want to focus? That is why I'm taking pause, slow down myself. That is, already we have discussed, if dopa decarboxylase enzyme, which is present peripherally, it will break down the levodopa, and we know when there is a breakdown of levodopa would be converted into dopamine. And we know dopamine cannot crosses the blood-brain barrier. There is a problem. And second problem can occur. What is that? Because the level of dopamine in the periphery will raise, and this increased level of dopamine will disturb the different activities, especially activities related to cardiac activity. Because dopamine is cardiac stimulating activity or cardiac inhibitory activity? One of you. Dopamine having cardiac? No. Cardiac stimulating activity. Dopamine, dopamine is going to increase the heart rate, so it may lead to cardiac arrhythmias, tachycardia. In hypertension, hypotensive shock, we use dopamine to treat that shock. Right, now the answer is correct, cardiac stimulating activity. So, no, not levodopa. I am repeating again. When we administer levodopa, in the GIT, there is an enzyme, dopa decarboxylase enzyme. It will break down the levodopa. When levodopa is breakdown, it immediately converted into dopamine. Now the problem is when in the periphery, levodopa is degraded, it is converted into dopamine, and dopamine cannot cross the blood-brain barrier. So one of the problem that the required level is not going to achieve in the brain. And the second, the peripheral conversion of levodopa will raise the level of dopamine. And this is dopamine which is going to produce cardiac stimulating activity, right? So that means for achieving therapeutic concentration, we are required the high doses of levodopa. So if it's going to break down, no problem. So the level of can be achievable in the brain to produce its activity. But the drawback of giving high doses, what will happen? What will happen? Increased conversion of levodopa into dopamine in the periphery and increased disturbance in the cardiovascular activity. So can we solve this problem? Is there any point that comes in your mind that, okay, sir, we can solve this problem? We can solve this problem, or to decrease the breakdown activity, so maximum levodopa would be available in the brain and less amount would be available in the periphery, so we can avoid the cardiac stimulating activity. Anyone? Okay, there is a reply. Okay, if we inhibit this enzyme, dopa decarboxylase enzyme, right? So if we inhibit this enzyme, so what will happen? We can avoid the early breakdown or peripheral breakdown of levodopa. Very good, right? So there is a drug that is called carbidopa, which inhibit dopa decarboxylase enzyme. And this is the point, this is the question that is asked in the exam. Okay, how we can prevent peripheral breakdown of levodopa? By using carbidopa. So what is the mechanism of action of carbidopa? Carbidopa inhibit dopa decarboxylase enzyme, so there will be no conversion. So why we are interested to inhibit its peripheral conversion of levodopa? Because if levodopa is degraded, it is converted into dopamine, and dopamine cannot cross the blood-brain barrier. And number second, the peripheral conversion of levodopa into dopamine will produce side effects, especially related to cardiac stimulating activity that may lead to tachycardia, arrhythmias, hypertension. And another interesting point, dopamine, dopamine is emetogenic. It stimulates the chemoreceptor triggers on dopaminergic receptors, so it can induce vomiting. Clear? Adverse effects of this levodopa. Peripheral effects, we have anorexia, nausea, and vomiting because of stimulation of the chemoreceptor triggers on. Tachycardia and ventricular extrasystole result from dopaminergic action on the heart. So this point already we have discussed. Hypertension may also develop. Adrenergic action on the iris causes mydriasis, dilatation of the pupil. In some individuals, blood dyscrasias and a positive Coombs test. This point is important. Saliva and urine may turn brownish color because of the melanin pigment produced from catecholamine oxidation, right? So it may show the saliva and urine brownish color. CNS effects, visual and auditory hallucinations. We are discussing adverse effects of which drug? Levodopa. Clear? Visual and auditory hallucinations and abnormal involuntary movement, dyskinesias may occur. This dyskinesia, that is the abnormal involuntary movements, right? These effects are the opposite of Parkinsonian symptoms and reflect overactivity of dopamine in the basal ganglia, right? Levodopa can also cause mood changes like depression, psychosis, and anxiety. Now, this point already we have discussed. So, how we can avoid the levodopa breakdown, right? Here you fate of administered levodopa. When we administer levodopa, metabolized in the GI tract, so under a desirable side effect. Yeah. So after conversion, it is converted into dopa. Fate of administered levodopa plus carbidopa, because carbidopa inhibit this dopa decarboxylase enzyme. So what will happen? Decreased degradation in the GIT tract or other peripheral tissues. So we have the maximum level of levodopa that can crosses the blood-brain barrier and reaches the site of action. So this point is important, right? From the exam point of view. Dopa decarboxylase enzyme inhibitor, that is mainly carbidopa, benzerite. So this is another example. And this point may asked in the exam, Synmat. What is Synmat? Synmat basically is the combination of levodopa plus carbidopa. And why we have added carbidopa with levodopa, this point already we have discussed. Drug interactions The vitamin pyridoxine, this is very interesting point. You know, this vitamin B6, can you recall any other condition in which pyridoxine is required, is necessary? But if we are using levodopa, pyridoxine should be avoided. Very interesting. There is a condition in which pyridoxine should be avoided, and we have another condition in which vitamin B6 should be given. So in Parkinson disease, when we are using levodopa, pyridoxine, vitamin B6 should be avoided. But now tell me, what is the condition and where we must add vitamin B6? In which condition? Can you recall? Okay, with anti-tuberculous drug. Very nice, very good, very good. To avoid the peripheral neuropathy, because isoniazid that can reduces the level of pyridoxine that may lead to peripheral neuropathy. But in Parkinson's disease, if we are giving levodopa to our patient, the vitamin B6 increases the peripheral breakdown of levodopa and diminishes its effectiveness, right? Concomitant administration of levodopa and non-selective monoamine oxidase enzyme inhibitor. You know, monoamine oxidase enzyme inhibitors are of two types: selective monoamine oxidase enzyme inhibitor or non-selective monoamine oxidase enzyme inhibitor. If we are using levodopa with non-selective monoamine oxidase enzyme inhibitor such as phenelzine, can produce a hypertensive crisis caused by enhanced catecholamine production, right? Because in catecholamines, we have different amines, like catecholamine in which we have epinephrine, norepinephrine, then dopamine, then 5-hydroxytryptamine. Now, it is better to give the selective, use the selective monoamine oxidase enzyme inhibitor. So that we will see in the subsequent slides. What is the role of monoamine oxidase enzyme inhibitor? Now tell me, monoamine oxidase enzyme inhibitor can be used, monoamine oxidase enzyme inhibitor in the treatment of Parkinson's disease? Yes or no? Can we use monoamine oxidase enzyme inhibitors in the treatment of Parkinson's disease? Yes or no? Yes or no? Okay, there is a reply, yes. And how? Because, you know, already in the beginning of the lecture, already I told you, because there are different mechanisms by which we can raise the level of dopamine. So this is one of the phenomena that can raise the level of dopamine, because we know dopamine can be breakdown by enzyme monoamine oxidase enzyme inhibitor or catechol-O-methyl transferase enzyme, right? So when there is a inhibition, there will be no breakdown of dopamine. So this is how we can raise the level of dopamine. But one important point we must know, this monoamine oxidase enzyme inhibition is selective or non-selective. This we will see in the subsequent slide, in which we will discuss the specific group that can be used in the treatment of Parkinson's. But at this level, what we must know, if a person is having levodopa, it should be avoided to use monoamine oxidase enzyme inhibitor having non-selective activity. That means monoamine oxidase enzyme inhibitor are of two types, A and B. Non-selective means the drug that can block both type, A and B. This is called non-selective. And monoamine oxidase enzyme inhibitor, selective inhibitor, means either that inhibit monoamine oxidase enzyme inhibitor type A or type B. What is the clinical importance of this? That we will discuss in the subsequent slide, right? In many psychotic patients, levodopa exacerbates symptoms, possibly through the buildup of central catecholamines. So this already we have discussed. It is very tricky and very tricky for a physician if a person having both problem. Suppose that person having schizophrenia for which we are recommending antipsychotic drug, and at the same time that patient has to administer anti-Parkinson drug, right? So one of the group, when we are going to treat Parkinson disease, we are going to raise the level of dopamine. And in schizophrenia, we'll have to decrease the level of amines. So this is very tricky, right? So in the subsequent slide, we will see that in that situation, if a person having both problem, then we can use atypical antipsychotic drug like quetiapine and clozapine, so we can minimize the Parkinson problem. Cardiac patients should be carefully monitored for the possible development of arrhythmias. The mechanism already we have discussed related to this arrhythmia due to cardiac stimulating activity. Antipsychotic drugs are generally contraindicated. This point also we have discussed in Parkinson's disease because they potentially block dopamine receptors and may augment Parkinsonian symptoms. That may be labeled as the pseudo-Parkinson disease, right? However, low doses of atypical antipsychotics such as quetiapine or clozapine are sometimes used to treat levodopa-induced psychotic symptoms, right? So this point also we have discussed. Now the second group. First group, treatment of Parkinson's disease. Parkinson's disease can be treated by giving levodopa. Now the second group. In second group, we have salicylic. This drug is important, very older drug. So at least you must know the name of this drug, salicylic, right? And its mechanism of action. The new drugs are razaglin and safinamide, right? So this is the second group. And what this group is going to do, how this group is helpful in Parkinson's disease, through which mechanism? Here, salicylic, which is also called deprenyl, right? So this synonym you must know, because in some question, we just mentioned the name of deprenyl, right? Just to confuse the student, right? Because we expect that a student must know that salicylic is also called deprenyl. So sometimes we are not going to ask the question with the name of salicylic, rather we use the deprenyl. So you must know these are the same thing. Salicylic, also called deprenyl. What it's going to do, it selectively inhibits monoamine oxidase enzyme. The word is selectively. That means selectively inhibit type B, right? The enzyme that metabolizes dopamine. So why they are helpful? Because why this selectivity is important? Because dopamine is metabolized by the monoamine oxidase enzyme type B. So in this problem, we are just interested to raise the level of dopamine. We are not interested to raise the level of other amines, right? So when we inhibit this type B enzyme, specifically, we are going to stop the breakdown of dopamine. And it does not inhibit monoamine oxidase enzyme type A, which is generally metabolizes norepinephrine and serotonin. Now it's clear. So that is why the selective monoamine oxidase enzyme inhibitor leaves chances for the development of hypertension crisis. This hypertension crisis may be due to norepinephrine. If the level of norepinephrine is increased, if we are using non-selective monoamine oxidase enzyme inhibitor, because non-selective will inhibit both type B and type A. When we inhibit this enzyme activity, the level of norepinephrine is going to raise, and dopamine is also having cardiac stimulating activity. So it will increase chances of hypertension crisis. So these salicylic, razaglin, and safinamide, these are selective inhibitor of monoamine oxidase enzyme type B, because this type is responsible for the breakdown of dopamine. Okay, this selectivity can be disturbed. This selectivity is dose dependent. This is the general concept, just like in case of beta receptor agonist activity, right? So at low doses or normal doses, there is a selectivity. But if the dose is going to raise or in high doses, then this selectivity is loose, right? By decreasing the metabolism of dopamine, salicylic increases dopamine level in the brain. This point is clear, already we have discussed. When salicylic is administered with levodopa, it enhances the action of levodopa and substantially reduces the required dose, right? Salicylic is metabolized to, this point is important, methamphetamine and amphetamine, because CNS stimulant drug already we have discussed. So this is a very tricky point, because this salicylic having a metabolite which is methamphetamine and amphetamine, whose stimulating properties may produce insomnia if the drug is administered later than mid-afternoon. So this point we should, but this property, you know, can be misused. This is important, right? Misuse, right? Razaglin, an irreversible and selective inhibitor of brain monoamine oxidase type B, has 5 times the potency of salicylic. This is a new drug. Unlike salicylic, this is another important point of razaglin, is not metabolized to an amphetamine-like substance. So usually this drug should be recommended because it's powerful and there is no metabolite like methamphetamine or amphetamine that can be misused, right? Safinamide is also a selective inhibitor of monoamine oxidase enzyme type B, indicated for use as adjunct to levodopa carbidopa. The third group, catechol-O-methyl transferase. This is another one of the enzyme, because when the neurotransmitter is released in the synaptic cleft, so you know catechol-O-methyl transferase enzyme is present in the synaptic cleft, and this enzyme is responsible for the breakdown of different amines, right? So if we inhibit this enzyme activity, we can raise the level of dopamine. So normally, please focus on this slide. This is important. Normally, the methylation of levodopa by catechol-O-methyl transferase to 3-O-methyl-dopa, because this catechol-O-methyl transferase enzyme is also responsible to break down levodopa, because the key enzyme was the dopa decarboxylase enzyme, which was also responsible for the breakdown of levodopa, but that activity can be inhibited by using carbidopa. And this levodopa is also metabolized by catechol-O-methyl transferase enzyme. But bulk is metabolized, the key degraded enzyme is the dopa decarboxylase. But catechol-O-methyl transferase is also responsible for the breakdown of levodopa. So normally this process occurs. What is that? Methylation. The metabolic process is called methylation of levodopa by catechol-O-methyl transferase. It is converted to 3-O-methyl-dopa. Is a minor pathway for levodopa metabolism. You know, I am repeating again. Normally, the main metabolic pathway is through dopa decarboxylase enzyme, right? And there is another metabolic pathway is the methylation of levodopa, and this is converted into 3-O-methyl-dopa in a small quantity, right? However, now this second paragraph is important. When peripheral dopamine decarboxylase activity is inhibited by carbidopa, a significant concentration of 3-O-methyl-dopa is formed, because we have blocked the major metabolic pathway which take place with which enzyme? Dopa decarboxylase enzyme. But when we inhibit that major metabolic pathway for breakdown for the levodopa is inhibited by carbidopa, now the metabolic pathway will divert from major to minor. So normally the minor metabolite is produced, that is 3-O-methyl-dopa, but when the patient is using carbidopa, now the 3-O-methyl-dopa production will raise. So what is the important point? The important point is because this 3-O-methyl-dopa, right, is compete with levodopa for active transport in the CNS. That means this 3-O-methyl-dopa will inhibit the transportation phenomena of levodopa by competing. That means it will enter into the CNS rather than to levodopa should enter into the brain. So this is the explanation of this. So how we can avoid this problem? We can avoid this problem if we inhibit this enzyme. And at least you must know the name of catechol-O-methyltransferase inhibitors, and that is the entacapone and tolcapone. So these are the selectively and reversibly inhibit catechol-O-methyltransferase. So especially because, you know, already we have discussed initial starting therapy in Parkinson's disease, we start the therapy with levodopa. This is the normal protocol. So definitely a patient who is taking levodopa, definitely that patient is also taking carbidopa. Clear? So we can further improve the activity because when carbidopa is being used, so 3-O-methyl-dopa, level of 3-O-methyl-dopa will raise. Now this is how we come to know, because after even taking carbidopa, levodopa, response is not good. So studies are being conducted and it has come to know, okay, so this 3-O-methyl-dopa, this mechanism is involved. If we inhibit this enzyme activity, so we can improve the symptom. We can improve the life of that patient. So that is why the development of this entacapone and tolcapone. So they are going to inhibit catechol-O-methyltransferase enzyme. So inhibition of COMT by these agents lead to decreased plasma concentration of 3-O-methyl-dopa. So increased central uptake of levodopa and greater concentration of brain dopamine, right? So this is very important point that you must know. The pharmacokinetics of these drugs, can you recall the name of drugs related to COMT inhibitors? I just want to check your short-term memory. What are the examples of catechol-O-methyltransferase inhibitor? Okay, there is a reply. Not intracapone. Entacapone. Okay, entacapone is correct, right? Tolcapone and entacapone. So I think you have a good short-term memory. Entacapone and tolcapone. Yeah. Okay, pharmacokinetic oral absorption of both drugs occurs readily and is not influenced by food. This is important point because in levodopa, it is recommended that we should administer levodopa on empty stomach, right? They are extensively bound to plasma albumin with a limited volume of distribution. So that means it's not going to store in the body, right? It will remain in the blood due to limited volume of distribution. Tolcapone has a relatively long duration of action, probably due to its affinity for the enzyme compared to entacapone, which requires more frequent dosing. Both drugs are extensively metabolized and eliminated in the feces and urine. The dosage may need to be adjusted in patients with moderate or severe cirrhosis. Adverse effects. Both drugs exhibit adverse effects that are observed in patients taking levodopa, carbidopa combination like diarrhea, postural hypertension, nausea, anorexia, dyskinesias, hallucinations, and sleep disorders. But most seriously, this you must know, fulminating hepatic necrosis. That means fulminating means life-threatening. Life-threatening hepatic necrosis is associated with tolcapone. Therefore, it should be used along with appropriate hepatic function monitoring only in patients in whom other modalities have failed. Entacapone does not exhibit this toxicity and has largely replaced tolcapone, right? So though tolcapone having longer duration of action, less frequent dosing, this is the beneficial point. But the problem is increased chances of hepatic necrosis. So no problem, just to avoid the hepatic necrosis, okay, if we are required the multiple dosing of entacapone, no problem, but because less chances of hepatic necrosis. The next group is dopamine receptor agonist. We have two group of dopamine receptor agonist: non-ergot derivatives or ergot derivatives, right? So in the past, ergot derivatives generally we use, but due to side effects, now non-ergot derivative is being used, because you know ergot compound, they are powerful vasoconstricting ability. Even it may produce the gangrene, right? So that is why in current medical practice, we are preferably we are using non-ergot derivatives, in which we have ropinirole, rotigotine, apomorphine, right? And pramipexole. And ergot derivative, just we have bromocriptine. So bromocriptine can be used in the treatment of Parkinson's disease, but nowadays it's not being preferred because we have better alternative available, and this bromocriptine belongs to ergot derivative. Non-ergot derivative examples you must remember: ropinirole, rotigotine, apomorphine, and pramipexole. The important point that at least you must remember that in emergency situation, because you know for the quick response we are required the IV preparation, IV administration. So this is one of the beneficial point of this non-ergot derivative having dopamine receptor agonist activity. This apomorphine can be used in emergency situation where we are required the quick response, because this apomorphine can be used intravenously. So this point you must remember, right? So these agents have a longer duration of action than that of levodopa and are effective in patient exhibiting fluctuation in response to levodopa. Bromocriptine, pramipexole, and ropinirole are effective in patients with Parkinson's disease complicated by motor fluctuations and dyskinesias. However, these drugs are ineffective in patients who have not responded to levodopa. This point is important. That means if the survival neurons are there, then levodopa can produce its activity, and then these dopamine receptor agonists would be effective. But if the survival neurons are not there, so that means levodopa is not going to show the response, or even these dopamine receptor agonists, they are also not going to show the response. Apomorphine is an injectable dopamine agonist that is used in severe and advanced stages of the disease to supplement oral medications. The actions of the ergot derivative bromocriptine, this point already we have discussed, are similar to those of levodopa, except that hallucinations, confusions, delirium, nausea, and orthostatic hypotension are more common, whereas dyskinesia is less prominent, right? In psychiatric illness, bromocriptine may cause the mental condition to worsen, right? It should be used with caution in patients with a history of myocardial infarction or peripheral vascular disease due to the risk of vasospasm. This point already we have discussed. Because bromocriptine is an ergot derivative, it has the potential to cause pulmonary and retroperitoneal fibrosis. So this is the point that can be asked in the BCQ, right? Now the next group and the drug which is called amantadine, and basically you know this amantadine, initially it was discovered as antiviral drug, right? So basically this amantadine is the antiviral drug, but it increases dopamine release, and it also inhibits and D-aspartate type of glutamate excitatory receptors, and the drug has little effect on tremor, but it is then the anticholinergics against rigidity and bradykinesia. The last group is the anticholinergic. In the beginning, already we have discussed there is imbalance between the dopamine activity and acetylcholine. When there is decreased level of dopamine, definitely the excitatory activity of acetylcholine will raise. So it will show the movement disorder. So one of the phenomena could be to block the acetylcholine activity. So we can use anticholinergic drug for this purpose, and it will block the action of striatal cholinergic interneurons. And examples. So if you just know the example, that would be enough. Benztropine, piperidine, and trihexyphenidyl. So these are the specific. There is a long list of anticholinergic drugs, or we can say antimuscarinic drugs, in which we have atropine, in which we have scopolamine, right? So, but specific anticholinergic that can be used in Parkinson's disease, we have benztropine, piperidine, and trihexyphenidyl. And its activity is more effective against tremor than rigidity and postural disturbance. So this is all about. So I have tried my best to summarize the important drugs that can be used in the treatment of Parkinson's disease, right? So thank you so much.